This lecture is regarding the avascular necrosis of the femoral head. The objectives of this lecture are that by the end of the lecture, the student should be able to describe the normal blood supply of the femoral head, describe the etiology and risk factors related to avascular necrosis of the femoral head, describe common clinical findings which are typical to AVN, differentiate AVN from other causes, describe in detail the various stagings or classification used for AVN, and describe the various treatment options which are available for patients with AVN. So what is avascular necrosis? Which can be a result from numerous potential causes, which include trauma, steroid use, alcohol consumption, coagulation disorders, hemoglobinopathies like sickle cell anemia, thalassemia, etc., autoimmune diseases, liposomal storage diseases, smoking, and hyperlipidemia. Bones which undergo osteonecrosis typically are the femoral head, the scaphoid, the humeral head, and the talus. The death of the bone cells from the femur due to multiple risk factors and pathogenic process, individually or synergistically, following ischemia, cellular toxicity, or altered differentiation of mesenchymal cells, all contribute to the pathogenesis of AVN. The etiology includes either ischemia, direct cellular toxicity, or altered differentiation of the mesenchymal cells. Ischemia can be following vascular disruption due to fractures, dislocations, or any surgery. It can be also following vascular compression due to steroids or alcohol use. It can be due to intravascular occlusion such as thrombosis, such as in blood disorders, embolization such as fat embolization or air embolization. Direct cellular toxicity can be following certain pharmacological agents, irradiation, or oxidative stress. Altered differentiation of mesenchymal cells following increased adipogenesis and decreased osteogenesis can also lead to AVN. This can be induced by corticosteroids or alcohol as well. The normal blood supply of the femoral head is by the medial and lateral circumflex artery. These are branches of the deep femoral or profunda femoris artery. These first form an extracapsular or extrasynovial ring around the intertrochanteric area of the femur. From these, retinacular or ascending cervical arteries arise, which have four branches: the anterior, posterior, medial, and lateral branches. These branches ascend intrasynovially or intracapsularly towards the femoral head. Out of these, the lateral retinacular arteries are the largest group. These then form a subsynovial anastomosis at the junction of the head and the neck where the articular surface is present. The major contributor to this ring is the deep branches of the medial circumflex femoral artery. In cases of trauma, this intrasynovial ring is disrupted, which causes AVN eventually. Additional supply is also by the artery of the ligamentum teres, which is a branch of the obturator artery. The blood supply of the femur head changes and is different for different ages. At birth, the primary artery which is supplying the head is the lateral epiphyseal artery. From 4 months to 4 years, the ascending cervical branches, which are the metaphyseal and the lateral epiphyseal vessels. The metaphyseal branches eventually decrease after 4 months of age. From 4 to 7 years, the lateral epiphyseal artery is the only source of supply to the epiphyseal plate. Between 4 to 7 years, the lateral epiphyseal artery is the only source of supply due to the epiphyseal plate. From 9 to 10 years, ligamentum teres vessels increase the supply and anastomose with the lateral epiphyseal vessels. At adolescent, the extra-articular arterial ring, ascending cervical arteries, artery to the ligamentum teres, epiphyseal and metaphyseal vessels all supply the femoral head. In cases of trauma, as we discussed earlier, the subsynovial vessels are disrupted, causing AVN. There is a large regional variation in the prevalence of AVN, which suggests a multiple etiopathogenesis and also individual variations in the development of this disease. The diagnosis includes a detailed history for all risk factors and a thorough physical examination. Risk factors to be taken in history are history of trauma or previous hip surgery, smoking, tobacco, alcohol, use of long-term or high-dose steroids or any other drugs, association of blood disorders in the patient or in the family. The most common presenting complaint in non-traumatic avian is pain. It is typically a deep pain in the groin which may be referred to the ipsilateral buttock or knee. There might be decreased range of motion which is experienced by the patient, which limits the movements of the patient. There are clinical features of an irritable hip, and in case the patient presents late, there may be clinical features of osteoarthritis of the hip. On examination, the internal rotation is restricted significantly. A sectoral sign may be seen. A sectoral sign is a differential rotation of 20 degrees in different positions. Often, if the range of motion in internal rotation and extension is restricted, which improves when the patient's hip is flexed, then sectoral sign is considered positive. A cateral sign, which is passive flexion of the hip leading to external rotation, can also be seen in avian cases. Axis deviation test. A normal negative test is when the hip is flexed to more than 90 degrees with a flexed knee. In these cases, the knee and patella face outwards and towards the opposite shoulder. Test is positive, the knee and patella faces the same axilla or shoulder. Always remember to examine the contralateral hip because non-traumatic avian often is bilateral. An X-ray of the pelvis and bilateral hip in AP and frog-leg lateral views are ordered to assess the avian. Expected findings include a cystic or sclerotic changes in the femoral head, a crescent sign which you can see here represents the early delamination of cartilage from the bone and is carrying a poor prognostic sign. This means that the cartilage and the bone have been separated and the femoral head is about to collapse, which may distort the overall sphericity of the head. There are varying degrees of flattening of the femoral head, which also depends on the stage at which we are doing the radiograph. The crescent sign is called a crescent sign because of the crescent of the moon, which is very similar to what we see on the radiograph. An MRI is the investigation of choice and it helps in early detection of avian as compared to plain radiographs. We should be able to determine the extent, staging and progression of the disease based on MRI. It also helps out plan our treatment and rule out other differential diagnoses. A bone scan, if done, will show a decreased uptake because of the dead necrotic bone, which you can see here. The Fickett and Arlett classification for osteonecrosis has 4 stages. Of these, in the third stage, the crescent sign is seen along with the flattening of the femoral head, loss of sphericity and collapse. In the fourth stage, there is degenerative changes in the acetabular cartilage along with osteoarthritic findings on pathology. The Steenberg classification has 6 stages with stage 0 with a normal or non-diagnostic radiography, bone scan on or MRI findings. In stage 1, there is normal radiographic findings along with an abnormal bone scan and or MRI findings. A, B, C are subtypes or subclassifications in which mild is less than 15% of the head is affected, moderate is 15 to 30% of the head is affected, and severe is more than 30% of the head is affected. In stage 2, lucent and sclerotic changes are seen in the femoral head, which can be further subclassified as mild, moderate or severe. In stage 3, where the crescent sign is available but without flattening. In stage 4, there is flattening of the femoral head. In stage 5, there is joint narrowing and or acetabular changes which are seen. Here, there are again subclassified into A, B and C depending on the head involvement as well as the acetabular involvement. And in stage 6, there are advanced degenerative changes. Arco's classification for osteonecrosis is also used. Regarding the natural history and prognosis, symptomatic AVN is always progressive. Prognostic factors include the extent of the necrotic lesion, the location of the lesion in the head, the presence of bone marrow edema in the proximal femur, a combined necrotic angle which can be calculated on MRI, which you can see here. If the combined necrotic angle is less than 190 degrees, there is a less chance of collapse. Between 90 degrees to 120 degrees, it is indeterminate, which means there is a 50% chance of collapse. If the angle is more than 240, then there is a high chance of collapse. Poor prognostic factors for joint preserving surgery include a crescent involving more than 30% of the joint surface, a combined necrotic angle more than 240, articular collapse more than 2 mm, a large cartilage defect which is noted on MRI, an unstable patient who is unlikely to adhere to the post-op instructions. Differential diagnosis for AVN include tuberculosis of the hip, especially in developing countries, transient osteoporosis of hip in females, primary osteoarthritis of the hip, a healed Perthes disease, and old femoral head fracture with secondary osteoarthritis. Regarding the tuberculosis of hip, if we are suspecting tuberculosis of hip, are pain and restriction of movement. Points against AVN include a history of constitutional symptoms which are typically seen in tuberculosis of hip, a history of pulmonary TB or contact history, and in TB hip there is early destruction of the hip joint which is not seen in AVN. In AVN, the hip joint or osteoarthritic changes are delayed. In case of transient osteoporosis of hip in females, a young or middle-aged man or a female in the third trimester of pregnancy are typical candidates. Pain that intensifies with walking or other weight-bearing activities is typical of this disease and it also favors AVN. However, a sudden onset of symptoms is seen in this disease, unlike AVN. The pain subsides over 6 to 10 months in this disease, unlike AVN where the pain progressively increases without intervention, and no obvious risk factors have yet been identified for this disease. Primary osteoarthritis of the hip and AVN have both pain and restriction of movement which are in common. A history of trauma may be falsely attributed to the symptoms in this case. A deformity of the head and sectoral signs are typically seen in AVN which are not seen in osteoarthritis of the hip, and the progression of the symptoms can also give a clue regarding the disease. Healed Perthes disease typically has a limp first, followed by pain which is there in the later stages, unlike AVN where pain comes first followed by the limp. Age of onset of symptoms can also help differentiate AVN from a healed Perthes disease, and hip joint is relatively preserved in this case. To make a diagnosis, a detailed history and examination is very important, along with a supplemental X-ray and MRI, which will help us achieve a diagnosis. Surgical options for AVN can be divided into hip preserving and hip sacrificing options. Hip sacrificing options include a total hip arthroplasty, a resection arthroplasty or an excisional arthroplasty, hip resurfacing procedures, and a hip arthrodesis which is now obsolete. Hip preserving options include core decompression, non-vascularized and vascularized grafting procedures, proximal femoral osteotomies, application of osteogenic strategies like growth factors with or without any delivery systems, and osteochondral reconstruction. Core decompression is often the first treatment in the pre-collapse stage. Our objective of performing this procedure is to buy time and prevent collapse by allowing the necrotic bone to heal. It relieves the venous congestion and the increased intraosseous pressure, which gives immediate pain relief to the patient. Many techniques have been described using single or multiple tracts, but their objective remains the same. Bone grafts, bone substitutes, or angiogenic factors may be used in supplementation to this. In the post-operative period, protected weight bearing must be observed. Here you can see that the necrotic segment, which is the superior anterior segment, is being targeted by the guide wire. Once the guide wire has reached its objective, the core decompression can begin. By this, the necrotic segments are removed, which allows healing, and in the tract, bone grafting can be done. Bone grafting involves the removal of diseased segment of the head and supplementing it with the bone grafts. It is very useful for pre-collapse stage where the head is still spherical. Bone grafting can be done by a lateral cord tract using a femoral window, which is called the light bulb procedure because at the end of it the femoral head looks like a light bulb, or from the articular surface, which is the trap door approach. The articular surface of the femur is exposed using a Ganz safe surgical dislocation, and then the necrotic tissue is removed. The advantage of lateral core tract grafting is that it is simple, minimally invasive, no surgical dislocation of the hip is required, there are very less complications and very easy to perform in case of bilateral AVN. The disadvantages are that the direct joint is not visualized in this case, accuracy may not be 100%, and the chance of pathological fracture is present because of the lateral entry through the neck. In the femoral neck window procedure, it gives us better access to the femoral head and neck. There is less chance of cartilage damage. However, the chance of pathological fracture still remains. The articular surface window gives us direct visualization of the cartilage and allows accurate placement of the bone graft. However, it is very risky because a Ganz surgical dislocation is required, which is very challenging. It can cause iatrogenic cartilage damage and it can increase the chances of AVN if it is an alternate diagnosis. So, bone grafts can be non-vascularized or vascularized grafts. Non-vascularized graft can be either a cancellous bone graft from the iliac crest or fibula. Vascularized bone grafts can be either a local pedicle graft in which no microvascular anastomosis is required, which include muscle pedicle bone graft, or it can be a vascularized pedicle bone graft. Free vascularized graft require microvascular anastomosis, for example, a free fibular graft. Another surgical option are the proximal femoral osteotomies. The aim of these surgeries is to remove the necrotic area from the principal weight-bearing area. This is useful for small and medium-sized lesions, and it is also a time-gaining procedure. A valgus or varus osteotomy may be done. A rotational osteotomy is also possible, and a valgus extension intertrochanteric osteotomy combined with curettage can be used for AVN and the avascular segment. This is an example of a rotational osteotomy in which you can see that the weight-bearing part is on the anterior-superior surface of the femur. After performing the osteotomy, we can see that we have rotated the osteotomized fragment so that the weight-bearing avascularized part is now below and a new weight-bearing part has been formed. This weight-bearing area has intact cartilage. Arthroplasty is the final treatment for avascular necrosis in which the head sphericity is lost or osteoarthritic changes have occurred. We can perform a total hip arthroplasty, a hemiarthroplasty in cases where the acetabulum is still intact, and accessional arthroplasty may also be done but rarely these days. The role of conservative management is very limited. We can ask the patient to use a stick in the opposite hand to unload the hip in cases of unilateral avascular necrosis. No weight bearing should be done to prevent further damage, and there is poor evidence regarding medical management for AVN. Newer procedures include a femoral endoprosthesis, acrylic cement injection, and porous tantalum rods. Cell-based strategies such as expanded autologous mesenchymal stem cells and hematopoietic precursor cells have been used. Growth factor based BMP, IGF-1 and 2, TGF, PDGF and FGF have also been used. Vascular endothelial growth factors have also been explored along with granulocyte stimulating factor, and stem cell factor. To conclude, avascular necrosis has a multifactorial pathogenesis. A detailed history and examination is essential to come to a diagnosis. MRI is useful in the early diagnosis of the disease and also to rule out other differential diagnoses using clinical and radiological investigations. The primary treatment remains surgical. However, newer modalities like biological therapies are being explored. Thank you for watching this video. Please like, share and subscribe.